Welcome to the March ERA Journal Club. Each ERA e-seminar usually takes place on the last Thursday of the month at 1700 Central European Time, which is 1600 Oxford time. And unfortunately for our speaker today, it's about 3 a.m. In Australia. So we're extremely fortunate and very grateful for her to join so early in the morning. So each of the e-seminars are handpicked from a range of topics, of original recent research, or a key review article from NDT or CKJ, and the author or authors introduce their work. We always have at least one panel expert panel member. Today we're extremely fortunate that we've got two who I'll introduce in just a short moment. So today's Journal Club will be moderated just by myself, Parminder Judge, and I've got apologies from my usual co-host, Professor Will Herrington, and we're both Oxford-based nephrologists, clinical trialists and kidney epidemiologists. So the discussion is always focused, fairly informal, and we encourage live and hopefully lively questions for all the listeners typed into the Zoom Q&A box. As you're aware, it will be recorded, and all of the presentations are made available on various video platforms afterwards. So please do keep an eye on social media for links. In addition, I'm really pleased and excited to report that ERA is launching a real-time translation, audio and caption with AI in 7 languages, so French, German, Italian, Portuguese, Russian, Spanish and Turkish. Please note that this is a pilot test and we apologise for any mistakes in translations, and we hope that these will continue to be improved in the coming e-seminars. But to enable this function for the audio, please do click on the global icon at the bottom near the polls function and choose your language. And for the captions, you'll get an external link to access through the browser, which will be provided in the chat shortly. So moving on to the topic and the speakers, today's topic will cover the impact of suspensions from the deceased donor kidney transplant waiting list on long-term survival. And we know that a patient's journey on the wait list is very complex and may be compounded by suspensions for a variety of reasons, including infection, surgery, social reasons, amongst others. And patients often return sort of at least once, sometimes multiple times, or occasionally never back to that waiting list. And there's lots of disparities that may exist in clinical outcomes between patients who are suspended and those that who never get suspended. So today's study aimed to review some of those factors associated with transitions, and the paper was published online in November in 2023. So we're delighted today to have the senior author of the paper, Nicole de la Mata, and Dr. de la Mata is a career biostatistician, researcher and senior lecturer in biostatistics at the University of Sydney, and her expertise lies in establishing data linkage studies and using these to apply advanced statistical models to understand the patient's journey in complex clinical scenarios. And her work broadly is aimed to improve health service quality and efficiency to translate into better and more equitable patient outcomes. So I'd like to take the opportunity to thank you, Dr. de la Mata, for bringing your work to NDT and to this ERA Journal Club, and particularly so early in the morning, and whilst you're on maternity leave, as we discover. So huge thanks to you. We're also additionally extremely fortunate to have 2 external panel members with us today. I'm very grateful to Dr. Matthew Robb, who's the principal statistician within the Statistics and Clinical Studies team at the UK NHS Blood and Transplant, NHSBT. Matthew supported the UK Living Kidney Donor Sharing Scheme, the Blood and Transplant Research Unit and the ATOM study. And he's currently the statistical lead for the living kidney transplantation at NHSBT. And we're also extremely grateful also to have Dr. Gareth Jones, who is a consultant nephrologist and transplant physician at UCL Department of Renal Medicine at the Royal Free. And his areas of interest are living donation, incompatible renal transplantation, and transplantation of the diabetic recipient with either islet or solid organ pancreas transplants. And he also has a lot of involvement and works alongside Matthew at NHSBT. So huge thanks to both of you for joining and sharing your knowledge and insights, especially immediately prior to an Easter bank holiday weekend. So without further ado, we have a very stimulating topic and leading experts available, a live presentation and discussion. So please do take full advantage of the chat function and Q&A box to submit your questions for the presenters and our experts, and please don't be shy. And without further ado, Dr. De La Mata, please do share your screen and start your presentation. Thank you.
Thank you so much for the kind introduction. And thank you so much for inviting me to be here about not the best time in my zone. So I don't have any conflicts of interest to disclose. Gloria given a nice introduction to this paper that was published in NDT. This was supported by an NHMRC partnership project grant with the application number there. So this work is focusing on the kidney waitlist in Australia, and I'll just start with a bit of background on that. In Australia, people cannot enter the kidney waitlist until they start dialysis, and waiting time is considered from dialysis initiation. What this practically means here in two examples that we have is that people who spend a lot more time in that pre-assessment phase on dialysis will likely have a shorter active waiting time until they receive their transplant, and that's because of how waiting time is prioritized in the algorithm. What this means is that they're likely to have different journeys on the waitlist. So individuals can be removed from the waitlist and returned to the waitlist once or several times. And this removal from the waitlist is sometimes referred to as many different things. So it can be called delisted, or being off the waitlist, or being suspended. So for the rest of this presentation, I'm going to refer to this as being suspended. These suspensions can be temporary, and this can be such things as additional screening, so cardiac screening that may need to be done, or a more permanent suspension such as a new health condition such as cancer. And while people on the waitlist are counselled on expected waiting times for their transplantation, they're less aware about what happens when a potential suspension comes up and what their outcomes may be. It is possible that disparities in who gets suspended and who returns to the waitlist do exist. And this is somewhat supported in other work, and this has been done in, I guess, in a very superficial way, which we do see sex differences in kidney transplantation. So we do know that women are less likely to be listed and wait longer once listed, but there's been no real interrogation of what happens while on the kidney waitlist, and so that's what we sought to do. We wanted to describe the patient journey after entering the waitlist to receive their first kidney transplant, including suspensions with a particular focus on being active on the waitlist and being suspended, and also look at factors associated with these transitions on the kidney waitlist. And this is regardless of whether they eventually received a transplant or not. We undertook a cohort study, and we used data from the Australian and New Zealand Dialysis and Transplant Register, and this had available waitlisting information for everyone in Australia between 2006 to 2019, including their deaths, other clinical information, and their last known follow-up, which for most people was, we didn't have many people lost to follow-up in these scenarios. And as mentioned, our study population only include those who were entering the waitlist during that period to receive their first kidney transplant, but we followed them up for their entire journey after that. So we used a multi-state modelling approach to look at their transitions on the waitlist. So I'll walk you through this. Everyone enters into the waitlist becoming active, and that's when we started follow-up. People may be suspended once or several times, and they may return to the waitlist once or several times. Transplantation, living donor or exchange donor transplantation can occur when they're suspended or when they're active on the waitlist, but deceased donor transplantation only occurs if they're active on the waitlist from that state. After transplantation, graft failure can occur, and they would return to dialysis, and they may return to the waitlist again for their second or more transplantation. And death can occur at any given time. So we gave a descriptive summary of what happened on the waitlist for our patients, and we used two modelling approaches to evaluate associated factors. So the first was to look at transitions, and we used flexible parametric survival models to look at that transition from waitlist to suspension and suspension to waitlist, so returning to the waitlist. While we used a Cox model to look at endpoints and these ignored transitions, and we were interested in receiving their first kidney transplant and death while waiting. So I haven't given a summary of the demographics of our study population, but you're welcome to look at that in the paper. And what I'll start off with is this Sankey plot that we have in the paper. So we included a little under 8,500 people who were entered the waitlist. And I'll just focus on some of these points here. So by the end of follow-up, nearly 80% had received a transplant. 72% was deceased donor transplant, living donor transplant was 6%, and exchange transplant was 1%. By the end of follow-up, 6% did remain in that suspended state, 10% was still waiting, and 5% had died. And this is up until their first kidney transplant. So what this plot does is each colour represents each of these clinical states that I had just spoken about. And the block in which we see the colour changes is the median time that this occurs in our population. And again, just reminding that this is years from entering the waitlist. This is not total waiting time. So everyone is active on the waitlist when they enter into our study, and that's given in yellow. And we see in our suspended group, who were suspended at least once, 37% were suspended at least once, and this occurred at a median time of about 7 months. 51% of our population did receive a deceased donor transplant without any suspension. 4%, similarly 4% received a living donor transplant, and less than 1% received an exchange donor transplant without any suspension. 8% were still waiting, and less than 1% died. So just focusing on these people who were suspended, these 3,000 people who were suspended at least once, we see that nearly 2,500 of them did subsequently return to the waitlist. So this was 78% return to the waitlist after their first suspension. Of our 3,000, 1,000, so roughly again a third, were suspended at least one more time. And again, we see a roughly 70% did return to the waitlist, so slightly lower proportion than in the first instance. If we look at what happens after they return to the waitlist, we see in the first instance, 50% did eventually receive a deceased donor transplant. And in the second instance, this is higher at 85%. In the suspended state, there's other outcomes. So we see that 8% did die while they were suspended after the first instance, and 10% after the second instance. And this is relatively stable, we see in both of those occurrences. So moving on to another figure in our paper, and this is looking at the expected probability or proportion that's going to be in each of these clinical states. And this considers their entire follow-up. So this is not just until their first transplant, but also beyond that. And this is why we have these graph values down here as well. So we see, again, this is from entering the waitlist. So we see 100% of them entered the waitlist in the first year. From entry. At the first year, we see that deceased donor transplant is hovering about 40%, and 40% are still active. And as we go through the years, deceased donor transplantation reaches a peak of about 62% after 4 years. Conversely, we see that the proportion who are active on the waitlist does reduce over time to about 5% by the 5th year. And the proportion who are in the suspended state is relatively stable at about 10 to 12%. The graph values reach a peak of about 2%. It does slightly increase, but it's mainly from the 3rd year onwards that we see that stabilizing close to 2%. And the probability of death here also increases over time to about 13% by the 5th year. Moving on to factors associated with the transition. So on the left here, we have active to suspension, and on the right, this is suspension to active, so returning to the wait list. We do see many socio-demographic factors are associated. So anything to the right of this red lines here indicate that the transition is more likely, and to the left, it indicates that it's less likely. So I'm just, in the interest of time, I'm going to focus on a couple of these, one of them being sex. We see that being suspended, sex is not a significant factor. It's not associated with being suspended, but it is associated with returning to the wait list. And we see that males are 10% more likely to return to the wait list after suspension. Really similarly, ethnicity was not associated with being suspended, but it was in returning to the wait list. And we see that people of Aboriginal and Torres Strait Islander ethnicity were about 30% less likely to return to the wait list. In the paper, we also discuss how these two factors, so sex and Indigenous status, are effect modifiers. So in fact, we only see that the non-Indigenous males have this benefit of returning to the waitlist more likely compared to their non-Indigenous females. We don't see the same effect in the Indigenous population. So Indigenous males have the same likeliness of returning to the waitlist of their Indigenous female counterparts. Looking at the effect of suspension now, the number of times of being previously suspended on being suspended and returning to the waitlist, we do see that they are strongly associated, and this is suggestive of a compounding effect. So those that were suspended were at an increased risk of 3 to 5-fold of having another suspension, and they were also at increased risk of 50 to 70% of returning to the waitlist. So what this does suggest is this is quite a transient population. Now looking at the factors that were associated with the endpoints. So on the left here, we have deceased donor transplant, and on the right here, we have death while waiting, and similar hazard ratios indicating if it's more likely or less likely. Again, we see several socio-demographic factors that were associated. Males were 11% more likely to receive a deceased donor transplant compared to females. Looking at the effect of suspension now, we do see that the number of prior suspensions is associated with a reduced likeliness of deceased donor transplant. And this is fairly consistent whether they had one prior suspension, or they had 2 or more, and this is about a reduction of about 30%. Prior suspension was also associated with death while waiting, but only in the instance of if they had one prior suspension, and we do see that this is a slight protective effect of about 30% reduced risk of death while waiting, and this is likely due to survivorship bias. So only those who are well enough to return to the waitlist at least once or only once were likely a slightly healthier population than those who had 2 or more suspensions, and we don't see that association in the 2 or more. What was strongly associated with this death while waiting is just being in the suspended state. So a lot of deaths do occur when they are suspended, and this is somewhat what we would expect in that patients become unwell and we remove them from the wait list. Also in the paper, I won't spend too much time on this, but we do provide some predicted waiting time. So again, this is waiting. This is time to first transplant from when they enter the wait list, not total waiting time. What we see here is what we would expect. Being suspended means that you have longer time on the wait list. And if we expect your transplant to happen in 2-year period, those who are suspended are probably waiting about 6 months longer. If we're expecting transplantation to occur over a 5-year period, then they're waiting about 1 year longer when they're suspended. So main findings in summary, a substantial proportion, 37% of our waitlisted population did have at least one suspension. I don't talk about this too much in this presentation, but it is in the paper. About half of these had a total suspension time of less than 6 months, but a fifth of these had 2 or more years suspended in total. 5 in 100 people did die while waiting, and suspensions were associated with an increased risk of further suspension, of returning to the wait list, reduced likeliness of transplantation, and being suspended increased risk of death while waiting. Intersectional disadvantage was also evident, so only our non-Indigenous males were more likely to return to the wait list after suspension. However, it is a good news story. There were still favourable outcomes among those who were suspended. 53% eventually did receive a transplant, but on average, this would take them about 1 year longer. So our findings show this lived experience of being on the kidney waitlist in Australia, and it also sheds light on some of these socio-demographic factors that are associated with this experience. It's important for informing patients and clinicians on the expected outcomes. As I mentioned at the beginning, they are counselled on expected waiting times and how their prior dialysis time contributes to that, but they're less aware about the potential for suspension and what that means for their journey. Our estimates could also help inform further research of economic models or our allocation algorithms and other such simulations. To the best of our knowledge, this is we haven't found other studies that have this level of granularity of what's going on onto the wait list. And so including these estimates could help better predict outcomes of a potential health service change. Future avenues of inquiry, which we haven't touched on in this paper, is a potential for transplant centre variation. So transplant centre organisation and processes may impact the length and the occurrence of suspension. This is something that we've started to look into in a New Zealand study that we are working on currently, and we do see quite variation between the centres, some having higher rates of suspension, but also higher rates of return. So what processes they have in place to facilitate that. Also, the potential for health interventions that can help improve and facilitate faster return to the waitlist for some key disadvantaged groups. So thank you so much for my presentation. If you're interested in our work, we do, this is nested under our Collaborative Centre of Organ Donation. We have a website and Twitter handle. The New Zealand work, which I've also mentioned, has its own website as well, and you're more than welcome to reach out to me. So thanks, everyone.
Great. Thank you so much, Dr. Della Marta, for such a exhilarating and stimulating paper and presentation. So over to our 2 expert panelists who may have some questions that they would like to kick off the discussion with.
Yep. Thank you very much, Nicole. Thank you ever so much for coming to present at 3 o'clock in the morning on Good Friday, in the middle of your maternity leave. I must admit, as I read through this paper, I think this is a really important point, but also what I would say is this is a really clear and very well written paper. It was a very easy read to actually get the information. So I think you and the team must be congratulated on that. I guess digging down into the data, the median time from activation to transplant was only 8.5 months, but the actual median wait in your paper was 2.6 years. So there's a group of patients who have spent 1.5 years or more on dialysis before they are activated as a median. So there are some people who spend a very long time on dialysis before they're activated, and some a shorter time. And that, we know, is associated with increased morbidity. You're picking up comorbidities, etc. Have you looked at total waiting time and their likelihood of being suspended from the waiting list and then subsequent impact?
Yeah, so we didn't present this in the paper. That's a very good point, and there are differences between that. You will see in the supplement, because I know a lot of people, talk about this difference as well, and we did want to sort of hyper focus on just their waitlist experience, so we didn't didn't really delve into it into the paper. You will see in the supplement we do have some histograms that quite nicely show that difference in when you consider time from waiting and when you consider time from when they start dialysis, and you can see those discrepancies in that, their distributions. Short answer is yes, we have done further models that have included that dialysis time, but it doesn't, while it might be associated with some of these outcomes, we don't find that it changes that relationship we see with prior suspensions and being suspended in some of those outcomes. So I should link this in. It might actually be on our website, but part of this work was to support a decision-making tool. When patients present to say that they need this transplant, they can put in their details of saying, I've been on prior dialysis this long, and I've, these are my clinical factors, my age, such as that. And that will give them a likeliness of how likely you are to be suspended at least once in your journal, and how likely you are to get transplanted. So this is, I guess, building onto bigger work. It's not talked about in this paper, but it is certainly explored in our further work that we're looking into.
And you may have, before I hand on to Matt, if I'd ask another question, have you, with the patients who are suspended and you show that they have more comorbidities, they're more likely to have diabetes, etc., have you looked at any post-transplant outcomes, i.e., if you're suspended, or if you're suspended more than once, do you have a much worse post-transplant outcome? Are you likely to lose your graft earlier? Have you looked at that at all?
Yeah, so we haven't looked at that, and that's a really good avenue we could look into. I guess part of this is the limitation of follow-up, and we have a very long, 13-year period of that. But if you consider that in the scope of someone who's having a transplant, how long it takes them to wait, how long that they have a functioning graft, beyond that, we don't see too many outcomes at this stage just because of that. So, in that 13-year period, very few, I think one of the paragraphs I took about, very few people had a second transplant after a graft failure, and no one had a third transplant in that period, just because it's such a long prelude that we're looking at. So I guess there's a potential to look at that as we get more data, but it is quite a small subpopulation, I guess. And yeah, we could look at that.
Good. I'll let Matt ask some questions.
Thanks, Gareth. So firstly, Nicole, I just want to echo some of Gareth's comments about the paper. It's a really good paper, and I particularly liked the multi-state approach you've used to the different transitions as well. So within that, and comparing it to the situation in the UK, there's some similarities in terms of the dynamics and the list, and some differences. One thing that I think there's a particular focus on in the UK at the moment is the longer term suspensions, and the way that this has been analysed is more in terms of the dynamics, in terms of the number of suspensions and then the outcomes. Did you consider any other approaches to some measurement of suspensions, such as the length of time suspended and that? Because it might be some differences within that number of suspensions. Some people might have had, one long-term suspension, and that might indicate they're not as healthy compared to some with many short-term suspensions, which might be something like going on holiday. So if you looked at any other approaches.
Yeah, so that that comment of going on holiday came up as well in part of the reviewer process. As everyone knows, I'm a biostatistician, I'm not a clinician, but I have heard from other clinicians that are part of this paper that it's going on holiday is probably not the biggest thing that's impacting these people. We're not seeing a lot of people on the wait list keen to be removed from the wait list because they want to go on holiday. That's sort of, I guess, a minority of people if that's coming up. We haven't delved into trying to look at patients that potentially have a lot of suspensions, and maybe they had a couple of short ones, and should we focus on the longer one and see how that impacts that? I guess that would be quite interesting I did mention in the paper as well the sort of average suspensions. So it does seem that, you know, most people have fewer number of suspensions, you know, 1 to 5 sort of suspensions, but there are those, I guess, a subpopulation with that can have 10 or more suspensions.
Yeah.
So how we look into, you know, delving into one of their suspension episodes as being a major impact on their journey, like that would be really interesting. We haven't looked into that. I guess it's important to note this modeling approach, though. It is a time to sort of event model, so it does consider sort of at any given time what's your I should say it inherently considers what the length of the suspension is, because that's part of how it considers the hazard ratio in are they more or less likely to transition, and that sort of reflects how long that they're being on the suspension. So I guess it's sort of inherently part of the analysis, but we haven't delved into it in that sort of individual way.
That's great, thanks. And I think, you know, a lot of what you've captured probably wouldn't differ too much, even if we looked at length, but there might be some subgroups with those longer term suspensions, and it might be that some of those, you know, differences we see in time to transplant and time to death that may be emphasized even more with those groups. So interesting to look at.
Yeah, certainly. So it's almost like going into some latent class modeling things to try and see if there's even hidden groups within the suspension group to see what different journeys they have.
And also with the comorbidities, they are captured as the number of, but within that, I think there were certain things you classed as comorbidities. Did you look at those different reasons in turn at all and see is any one type of comorbidity you know, affect your outcomes rather than the overall number?
No, and that's probably a really good point. So we are, you know, we did use ANS data, so we're limited to the few comorbidities that they routinely collect. There is the option for clinicians to lodge other comorbidities that a patient has, but that's not, I guess, systematically collected. So we were limited in that way. And yeah, there's certainly the potential that some of those comorbidities had more of an impact than others.
Okay, great. Thank you so much to both of our external experts. I just have one question, and I can see there's one in the chat. Just so following on from what Matt was saying, then sort of clearly some of the longer suspensions are likely to be a marker of sort of frailty and comorbidity, but it doesn't really seem to explain all of the sort of the inequity for the sort of indigenous populations, and sort of what you think might be affecting their likelihood of returning to the wait list, or if you've got any information on that. And then there's also a question in the chat, which I'll come back to in a moment.
Yeah, it is really interesting because even the sex as a factor coming up, you shouldn't see that coming up. We, as I've mentioned in the paper as well, we are limited in that we don't know the reasons for suspensions. We don't know how they, the reasons for suspension, which may give an indicator of how easily they can return to the wait list. Of course, we can speculate in health systems sort of perspective or health services perspective in the difficulties that they may be facing in just getting to appointments. So I guess the burden of just having to care for themselves and having to negotiate in a complex health service system may be part of why it takes them longer to get. And, you know, the same could be said for potentially for females in gender roles and how difficult it may be for them to coordinate that. And it may be less so in the male gender roles. But unfortunately, until we do further work, which may be qualitative work, where we can actually talk to patients and clinicians, we can't really speculate why we see that effect. But it is a good flag for us to research further.
Perfect. And then the final question in the chat is there a uniform procedure for sort of determining eligibility for transplantation across the whole of Australia, or is it or are there sort of centre specific sort rationales. For example, would clearance from a cardiological sort of perspective be enough of a reason to be considered for transplantation?
Yeah, so I'll just quickly say before I slightly hand over to the clinicians on this call, but there is the Transplantation Society of Australia and New Zealand that governs the eligibility rules across of Australia and also in New Zealand. That's freely available for everyone to research what those guidelines are, and they do get periodically updated. I'm not sure about if I don't expect there to be centre variations, but I guess there is the potential for some of those eligibility criteria to be under personal opinion. So, one of them being that you want the patient to be compliant, and how people may interpret people who are, I don't know, drug use or alcohol use, and that severity. There's always a potential for that. But Gareth,
Yeah.
what do you see?
Do you know,
as
this
well?
is, I smile because my other job for NHSBT is to try and unify practice across the whole of the United Kingdom, and I guess I think you answered that question beautifully. There are guidelines. I guess the issue is the interpretation of those guidelines, and I would be amazed if every single unit in Australia does things exactly the same. If they do, I'd really like to know how they've achieved that, because I think we could do that in the UK as well. So I see there will be interpretation. The other thing that we find is availability of tests, access to those tests, where some larger centres may have very rapid access to a whole wide range of tests, but some of the smaller centres or less well-funded centres may well have a smaller number of tests and have to wait an awful lot longer for those tests, etc. And that decides on your protocol. And then at the end of the day, it does come down to personal opinion of whether someone really is suitable to go forward for kidney transplantation. So if Australia has cracked it, let me know. Can I come back and I just ask you a couple of questions about your looking at your analysis of your likelihood of being suspended, and I can understand the sort of patients with diabetes and patients with higher comorbidities, etc. There's one slight one on age, which I can come back to, which would be unfair to ask you. But one of the things that really does stand out to me is if you're blood group AB, you're much more likely to be suspended. And I couldn't work that out because I'm classically in the UK, and I had a look at some of the ANZ data. You're likely to be transplanted a lot faster if you're blood group AB. So this may be an unfair question to you, but have you looked at that? Why are you more likely to be suspended if you're blood group AB?
Yeah, that was something that was quite hard for me to crack and talk about. And I guess, part of it, and I think I wrote it in the paper as well, is it is different from what is reported in other studies as well, where other blood groups are more likely, which they don't see in this AB blood group. So it could be variations in what the Australian population is who is waitlisted. I really don't know how that relates to being suspended, because again, it's something that you wouldn't expect to be associated with something which is
You're
quite
also
independent.
less likely to get back on the list if you're AB as well. Obviously, not statistically significant, but it's just an interesting observation there.
Yeah, and it might be that that group is particularly different in some other way, and that the blood group is just a flag of that. So
if you had the power over the allocation scheme, or with the data that you've got, how do you think you could build this data into an algorithm? Would you give them more points if they've suspended? How do you think you could work that?
I guess potentially with anything like the algorithm, you have to be careful if you're giving points to one group and how that incidentally affects other groups. And I would really like to, I guess, talk to more experts and possibly labby people in why we might see that come up, if that's an indicator of something else, or in this case that we haven't captured, or sensitivity or something like that, or health or something like that. I think that would be an important avenue to look at. But potentially, if it is a disadvantaged group, potentially.
And Nicole, I realize that the paper's still, you know, only recently been published. Have you got much feedback from the clinical and the patient community in Australia on, you know, what their thoughts are on the results? I know in the UK, there's particular interest in suspended patients, and especially so since the pandemic, where a lot of our waiting list was suspended. So but there's a lot of interest in, okay, what's the impact? What can we do differently? Are you getting kind of similar feedback from that with the Australian data?
Yeah, I think it was rather surprising to see that intersectional disadvantage for the Aboriginal and Torres Strait Islanders, and also females. So I guess that's something that has sparked some of the interest. As I said, this work, it was part of a foundation of other work to try and help decision making and to understand inequities in care in that transplantation process. So it's certainly, as part of that, an important pillar that has been well received. We have disseminated this to a couple of the local conferences, and it always seems to sort of spark a lot of interest into why we're seeing these and how we can think about the health service delivery for these populations.
Excellent. Well, thank you so much, Dr. Delamato. I don't think there's any other comments or questions from our other expert panelists. So I think we're probably about sort of ready to call time on today's e-seminar. So a huge thanks from the ERA Journal Club team to you, Dr. Delamato, Dr. Robb and Dr. Jones, for sparing your time today, especially sort of on the cusp of an Easter weekend, and for you it's already started and so early in the morning. So huge thanks once again for giving up your time today. I'd encourage all of our viewers who have joined today to go to the NDT website and read the paper if you haven't already done so, and do also check out sort of CKJ and NDT for other similar papers covering transplantation, and a wealth of suggestions from today's seminar. In particular, I'd like to draw your attention to a couple of papers that were recently published in NDT, one of which was published by Dr. Villar and colleagues, looking at a multi-center study of registration of renal transplantation waiting list of the elderly and patients with type 2 diabetes, which is very pertinent to some of the points raised by our panelists, as well as another paper from Dr. Rodoli and colleagues looking at lower access to kidney transplantation for women in France, which is apparently not explained by comorbidities or social deprivation. So please do go and have a look at some of the other material that's out there. And as always, before you go, please do answer the survey within Zoom, which the link for which should appear shortly. And we really do appreciate your feedback to help keep us and these e-seminars running, and sort of guide future formats and sort of any topics particularly that you'd be very keen to hear on. Whether you'd prefer a shorter format or any other edits, please do let us know your thoughts. But for now, it is goodbye from the panelists, external members, our speaker, the team at the ERA and myself.